Good afternoon. My name is Dr. Zephania Shira. I work for Aga Khan Home Care as the lead doctor. Today we have a very interesting topic, and we have a very good panel that entails some of our experts from the clinical psychology. And we have Merin Farouk, Kirti Dixit, and Timothy Mokua, who will be helping us to dissect a very important topic when it comes to early diagnosis and intervention of mental health diseases, and also when to call specialists to intervene on this, and also clinical assessment of suicide risk. These are things that plague us in our society. We've lost some colleagues in the healthcare profession and in the general public. So I believe this will be one of those keynote speeches that will help us maybe save a life here or there amongst the profession and the general public. As we have more of our colleagues joining, I want you to share it widely amongst your social media groups if you have the link, so that we can pass this important knowledge. I'll welcome our panelists, maybe Mr. Merin Farouk to take the lead and give us some key insights on this important topic. Then later on, after the presentation, we'll give you more insight on how you can access the specialists and also how you will get your CPD points. Thank you very much for your presence. I'll welcome Merin Farouk for the first presentation. Thank you very much.
Good afternoon, everyone. Thank you so much for making time and coming in today. And thank you for the introduction. Without wasting time, I'll want to share screen so I can have my presentation up. Please let me know if you're able to see the screen.
It's visible. You can put it on slideshow.
Okay.
Also audible.
Okay, here we go. Is this okay?
Excellent. Excellent. You can take it away.
So basically, it's the need of the time where the initial to reach out to now it's pretty much a call to the specialists, where we're trying to highlight early diagnosis and intervention of mental health disease. Before we get into it, I would like to highlight a misconception that we have with regards to mental health, because it's immediately associated with a mental health disorder. Mental health is basically enables people to cope with life stresses, and it's not necessarily a mental health disorder or a comorbidity of the sort. But for us to be able to reach that, definitely for us as mental health workers, we deal with mental illnesses. However, for a more collaborative mental health approach, we do need support from specialists and other medical workers, because as you can see, approximately 50% of lifetime cases of mental health illnesses actually begin very young, which is adolescent. And 75% in early adulthood, which is by age 24. The reason why I wanted to bring up this statistic was to highlight the importance of early diagnosis and intervention for holistic well-being of patients, therefore their mental health. Basically, the challenges that we are facing currently with regards to mental health is the stigma, especially in the East African region. We know that we still have some elements of stigma where we have patients not coming in for treatment because of fear of discrimination, social exclusion, reduced social support, and of course, delays in treatment. That's one. The other one is, of course, avoiding signs and symptoms, which is something that is also very universal. Sometimes it's by the patients, sometimes it's by the family, and sometimes it could be an entire social model, really, which is in turn resulting in delayed mental health diagnosis and treatment, which of course causes worsening of the illness comorbidities and generally a reduced quality of life. So these are some of the challenges that we're facing. To highlight on that, let's look at this where we have a visual outlook on the global burden of major depressive disorder. And if you look at it just as at a glance, the chunk of the patients is really the youth, the younger kids, starting from 14 and upwards. And I can not emphasize more on how important it is for us to reach out to these individuals before the situation worsens. Now, having stressed that out, basically, what is really early diagnosis? It's just simply identification of mental health conditions at the earliest possible stage, right? And early intervention is proper treatment at the right time, at the right place, which of course eventually will improve treatment outcomes, and we just nip it in the bud, like we say. However, we do feel that this, without the support of our specialists and other medical workers, including the nurses, it's impossible to build that gap. As much as we have, these are some of the tools for early detection for mental health workers. I don't want to undermine the fact that we're not equipped with tools. We have so many standardized screening tools, such as the General Health Questionnaire. We have Generalized Anxiety Disorder Scale, Depression, Anxiety Stress Scale. So we're definitely very well equipped. However, I need to highlight the role of the specialists, where despite being equipped, providing specialized support to people who are experiencing early symptoms of mental illnesses by medical specialists such as neurologists, cardiologists, even nurses and allied health professionals play a vital role in initial screening. And I want to highlight that even more: initial screening and identifying early warning signs. Of course, I know that I've been in hospitals myself, and we do have nurses that are well equipped with first aid counseling. And we have an excellent referral system at the Aga Khan University Hospital. So if I was to go back, as much as we have these tools, if we incorporate the role of the specialists, then definitely we have early diagnosis and intervention. What I wanted to do in this presentation was not just to highlight the importance, but just a little take home. I'm sure as professionals, we already know this, but I wanted to use the platform just for a quick reminder that let's remember the key signs when we're in our clinics, which would be behavioral signs like changes in mood, withdrawal, aggression. There could be cognitive signs that you could look out for, like difficulty concentrating, memory problems. Physical symptoms are, of course, number one for medical workers, like what we call psychosomatic symptoms. In other words, unexplained aches, changes in appetite or sleep patterns, worsening health. For example, in worsening health, let's say if we have a patient coming into a gynecologist, and we have this lady with depressive symptoms or postpartum depression, and we're seeing that the condition is just worsening by the day, and it's toppling over to major depressive disorder. So any form of worsening health, whether it's cardiologists, diabetologists, pediatricians, it could we need to be able to check in with, could there be a psychological element to it? And of course, we have the psychosocial indicators, which are isolation, decline in work performance, and relationship problems. So these are just some of the things which are only reminders to look out for, which would, of course, really build that a gap and bridge that we're trying to do with regards to early intervention, diagnosis, and overall improved mental health for our patients. And that is some of the benefits that we may have. Now, of course, having highlighted the population that suffers, we know now that it's the younger population to early adults. Having said that, we do have certain signs that we could look out for in our patients. And how do we do this? Let's equip and remind ourselves of some of the strategies, which is effective communication with mental health professionals. I know that at Aga Khan University Hospital, it is really teamwork for holistic care, and I feel very supported when we have effective communication with mental health professionals, even amongst ourselves and with other doctors, creating a supportive environment for everyone. What we could do is, I think we probably need to incorporate mental health discussions in routine care, perhaps for all specialists and doctors, where we're able to ask them about how are you feeling, what's going on, just a notch up in terms of how we do it every day. And of course, the referral to mental health services, which is the prime reason why we want to reach out to other services to help our patients holistically. So basically just routine screening, integrate mental health screenings. We have comprehensive care plans. I know a lot of us we have these packages, well-being packages, which is an excellent way to reach out to our patients. And general professional development for specialists, which is the very little that we're trying to do here as the department, is just to keep updated on mental health research and workshops like we have today. Referral pathways is very impressive here. It's just a click away for us to be able to help each other, help our patients. Like I said, I know that when I joined the department, the first training that I did was the medical records, and I was really impressed with how everything is so high tech, and it's just so much easier for us to reach out to one another, let alone we're talking to each other right now through our laptops or phones. So my conclusion would be that let us make mental health a shared responsibility, collaborate, educate, and intervene. So thank you so much. That's a little bit from me. If you may have any questions.
There's a good question from the inbox. Maybe you could respond to that. Okay. From Mahmoud. The last one.
Okay.
Requesting perhaps you could highlight from the tools, which ones are the gold standard as approved by the WHO?
Perhaps you could highlight that from the tools, which one are the golden standard as approved by the World Health Organization? That's a very good question. Of course, so let me go back to the slide of where that was. Are you still able to see my screen?
Yeah, yes, it's visible.
Um, so basically, these are generally standardized tests that are more in terms of APA approved. World Health Organization, I would believe, would recognize anything that is approved by the American Psychiatric or Psychological Association. So my take on that would be that any standardized screening tool test that is approved by the APA should also be approved by World Health Organization, but I would definitely appreciate some input from my teammates as well. But all these are standardized screening tool tests. They're verified, they're valid, and of course, extremely reliable.
Okay, there's a comment on the inbox that maybe we schedule these questions for later because of we have more speakers. But thank you for the feedback.
All right. Thank you so much. Thank you for your time, and thank you for allowing me this platform. I really appreciate it. So if I could, I think, exit the screen.
Yes, please. Yeah, I will welcome the next presenter to mount the slides and take it away, please.
Good afternoon, everyone. My name is Kirti Dikshit, and I'm one of the counselors at the hospital.
My name is Timothy Mukua. I'm also one of the counselors at the main hospital.
Today's topic is first aid on assessment of suicide. It's important that as a community, we are aware of it. So suicide is an important issue in our community. We need to ensure that we're not too afraid to talk about suicide while respecting and understanding the risks. So what is suicide? Suicide is the act or an instance of intentionally killing yourself. A suicide attempt, and so these are some definitions associated with the main definition. A suicide attempt is a non-fatal, self-directed, potentially injurious behavior with intent to die as a result of the behavior. So a suicide attempt will not necessarily result in self-injury, but it can. Suicidal ideation refers to thinking about or considering or planning of the act. These are some of the facts from 2023 from Kenya. So as you can see, we have rings. So this is like a ripple effect of the suicide or of the act. Reported suicides, not confirmed because many of them are unreported. We have another ring that also includes the unreported. So if you combine 1 and 2, that would be the total number of suicides. Suicide behavior is about 40 times more than the actual number. People with thoughts of suicide, about 5% of the population. And the people that are affected by suicide behavior, it's really impossible to say. Some of the factors that contribute to the suicidal ideation is identity factors, past history, psychological factors, biological factors, which is genetics, and current life events. So there's a grid over here that shows the intention versus outcome. The intent to die with an outcome of death is known as suicide. The intent to die versus the outcome of life is a suicide attempt. The intent to live with an outcome of death is accidental suicide. And the intent to live with an outcome of life is non-fatal self-injury. So which one is the most vulnerable group? So if I just take you back, the which one do you think is the most vulnerable group? And it's actually the non-fatal self-injury. So the one that has the intent to live but outcome of life. And this is because non-fatal self-injury, the stigma can lead to repeating. And unfortunately, people, the repetition of this would eventually lead to death if they succeed. We have other vulnerable groups, which are teens, people with history of mental health issues, and people who've experienced stressful and traumatic life events. So for the suicide screening, which my colleague will take you through in detail, we have 3 important steps, which is recognize and ask. Number 2 is listen and explore. And number 3 is coping. So I will hand over to Timothy to get into the details of that.
Thank you, Kilty. We'll focus on the suicide safety guide, a 3-step intervention. There's also intervention that I believe all the nurses do it in the triage process, and sometimes maybe from the doctors. Sometimes we check what the nurse has done. Sometimes we might even forget that this screening was done. But it's good to highlight the importance of this screening, so that as we see the patient, we're able to first of all check what was the outcome of the suicide screening that was done by the nurse. So in the step 1, we recognize and ask. The keyword is notice, tell, and ask. When a patient comes to you, the nurse or the person who sees them first, or even if it's your colleague, it could even be your friend, it could even be a child, your relative who has come to you, there are some possible noticeable signs that may make you feel that it's important you do the suicide safety guide. And one of them could be maybe how the person presents themselves. It could be you have noted how they are isolating, you have noted how low they look, or the item they are carrying. Probably some could have a suicidal note or something that you have just seen in their notebook. Let's say a child has come from school. And the next step is tell the person what you have noticed. If I have noticed a suicide note, I'll tell you. If I've noticed that you're isolating, I'll tell you. And then I can ask you, do you have any thoughts of harming yourself? Just notice that before you do the step 1, there's something you need to check: your safety and the patient of the person you're asking. Sometimes it is important not to do this if you notice it is very obvious that there's no safety, and you can ask for help first. And what are the questions are we asking? There are 4 questions, but there's also an additional 5 after you ask the 4 questions. The Ask Suicide Screening questionnaire. The question is a brief suicide screening question that only takes 20 seconds to administer. So that's why it is easy for this questionnaire to be used by the nurses, and anyone can do it when you are interacting with a patient or someone you suspect they could be having suicidal thoughts or ideations. What's the first question? In the past few weeks, have you wished you are dead? The question is very direct. Sometimes we always want to avoid asking such direct question, but in the suicidal risk screening, it's important you ask the question as it is, and the answer will be either yes or no. The second question is, in the past few weeks, have you felt that you or your family would be better off if you are dead? Our family could be even the people you are with, that you are living with, or maybe your immediate family and such. In the past week, have you been having thoughts about killing yourself? So you notice that we started from past few weeks. We can call them like maybe 6 weeks, we can call it 12 weeks. And then we are coming back to the third question, which is asking in the past week, that is just within the last 7 days, have you had thought of about killing yourself? And then the question 4, have you ever tried to kill yourself? Let's also capture if there's a history of attempted suicide or suicidal ideation in the past. Let's say the person in number 4, all among the questions say, yes, you'll ask how and when was that, when did that happen? It's important to know when it happened. So if the person was to answer no in question 1 to 4, the screening is complete and no other action is needed. However, notice that you have also a clinical judgment. It is possible that sometimes even when patients come for triage, they will say they are fine. And when they come to the doctor, they now pour out and the doctor asks, how come you did not say this to the nurse? It's because sometimes the patient could either mask what they are going through, or probably they maybe we didn't pick it at that point, that our clinical judgment could have made us know that that was a negative screen. Let's see if a patient say yes in one of the 4 questions. It is a positive screen, and that would mean that we need to go and ask another question, that is question 5, which is able to help us assess how imminent is the danger and how severe is the danger. So if the question is, if we can just go to question 5 for briefly to see which is this question. The question asks, are you having thoughts of killing yourself right now? Right now it's like you're with a person in the room, or it's a child you're with, and you're asking them, could you confirm right now? If the answer is yes, it means you have an imminent risk identified. And that would mean that this person would need to be seen by a psychologist and a psychiatrist. What you could do is like you can see who is accessible faster, because sometimes it depends on the timing on when you are doing this. Let's say from Aga Khan perspective, even in the evening or the night, there's even a doctor on call, and they can even link with a psychiatric who is on call that day. So it's important to know that during the daytime, it's possible to do that. Even in the night, if this was to happen, it's possible to also seek help for full mental health evaluation. If the answer is no in question 5, that does not mean that there's no risk, but there's a potential risk identified. However, there is a bit of downgrading of assessment to a brief suicidal safety assessment, which can also be done by a psychiatrist and also a psychologist. And sometimes you find that in case of a yes, there's high chances that the patient in question 5, yes, would be admitted. And in question 5, no, there's a likelihood that this patient can still be managed and still go home with medication. There are situations where the patient can literally not wish to answer any of the questions. And that's when you have to notice it's against medical advice that this person has literally refused to answer, maybe because of many other factors, or even the family members have declined to give permission for the patient to answer some of these questions. It could be many reasons why people could do that. So if that is done, you also need to go to step 2 to listen and explore. This is, I could say, among the difficult part, because of sometimes you say you don't have time, and probably you're not good listeners. So in this case, we are challenged to take care, to show care, listen, and be willing to learn and understand what is causing this person the pain they are going through. And we refrain from giving them solution, because it's very easy to dismiss what they are saying and tell them, I have also been there before and I overcame, so why is it bothering you so much? Or tell the person that's a very trivial thing. You should be celebrating or thanking God or your life or what you have, not just looking at what is not working. There's a time not to give solution. It's a time to explore, help the person pause not to make a major decision, because at this time, one of the major decisions could either be someone committing suicide. So therefore, there's a period where you ask someone to slow down fast, explore and understand what they are going through. It is noted that when someone feels heard and understood, chances of them reversing their thoughts that the only decision they had was suicide are high, and they might actually decide to look for other options. So this step 2 is very critical, that you could even avert a suicidal attempt or a suicide just by listening and exploring the person. I don't even know what answer to give. Then let's look at step 3. Here you are now building their strength and identifying their support, because now they may have come up with other ideas of what they can do to delay making such decisions, and probably they might be thinking of what else can they do. But then they're not able to access their strength. They're not able to even identify who will be my support structure. This is where you take them through and ask them, what is your support structure? Even if it is your house manager at that point, even if it's your a neighbor at that point, even if it's your religious person that you follow, or someone you know that you can access on spot, not someone very, very far from you. Someone probably who is just a door away, maybe a call away, and a very short distance near you. And if it's possible, someone who can be next to you, and probably in the space you are in. And also looking at what are the strengths. This is where the person will discover that I thought that I could not make it, but I realized that I have this other strength that I can work on. So help the person repeat back what they have committed. If possible, you can ask them to write down as an agreement with you, so that when they are going home, they'll be looking at what did they say. Sometimes we say that even if they have one support, it's good to challenge them to have more support. Let's say they have like 4 people who can support them. In case support 1 fail, I have support 2, support 3, and maybe among those support, as you who talked to them, you are among them, and also probably there's a support like a hospital or maybe a counselor that you have also connected the person with. Now, having done all that, remember you're also a tool being used in this process, and your way of interacting can also be harmful to the person you are helping if you're not doing self-care. So as you're preparing yourself to be a tool to help, like let's say if you are doing triage as nurses or maybe first aiders and such, allow that you also take care of yourself, including check how you take care of yourself physically. Are you eating? Are you sleeping enough? Taking breaks? Psychologically, do you write journal? Do you journal about what has gone on? Do you have any hobbies? Do you have a way to balance your life? And in case you feel overwhelmed, have you sought a counselor? What about your emotional balance? Do you understand that it's okay to feel you are worn out, you can cry, you can express your anger in a constructive way and such? Or how about, are you able to balance your work? I know sometimes it can be difficult, but sometimes it's good to enjoy eating your lunch, taking breaks, stretching, having a peer support, and even setting boundaries when you can be reached and when you cannot be reached, so that you can be able to rejuvenate. How about your spiritual self-care? Are you able to express your gratitude, meditation, prayers, and even listen to music? So what is the take home in our discussion? Let's see that suicide is really a result of a single event or factor, but it can be understood as a complex interplay of biological, psychological, and environmental factors that leave a person feeling desperate and hopeless about life. Before a person consider options other than suicide, let's note this, they will need to feel heard and understood. During this step, we need to listen to the intent to understand, not the intent to reply. In most cases, we want to reply, but in this case, we are asked, have an intention to understand first. And use the ASQ toolkit for every patient. And also add not only for every patient, it can also be someone you are suspecting. It could be even a clinical setting, because you can even rescue someone who could be going through a possible suicide by just observation, exploring with them, and ensuring their safety. So remember that we need to keep ourselves safe. and we keep this conversation so that this person can also get help. Thank you for your time. So let's check on how we have understood about the tool. How many questions that this tool has? I'm sure this will be very easy for nurses. 4, okay. Question number 2, what is question 4 in our ASQ tool? Have you ever tried to kill yourself? That would be number question 4. And number 3, what should you do if the answer to any of the question is yes? You need to go to question 5 to assess acuity, which means how severe is it and how imminent is it that this person is likely to hurt themselves. And then number 4, if the answer to question 5 in the ASQ tool is yes, you must, well, this is where we say that you require full mental health evaluation. So the answer is none of the above. And this is time where you also need to have a psychologist and a psychiatrist on board to help. And we could now be open for any question. We're willing to take any question. Thank you.
Thank you for the brilliant presentations, all 3 panelists. I'd welcome the members. Thanks for the good turnout. I just welcome the members to share, ask questions, share your experiences. If not, as we wait, maybe I can welcome some of the specialists in this field to also just give some extra comments. I've seen Prof. Atwoli on the chat. I'd welcome just to give us more insight. And also my question is, what is the appropriate term for this situation what's the current term for a patient for this condition? Or my question is, what is the appropriate term? Is it a patient died by suicide or committed suicide? Yes, thank you.
Committed suicide is, I know it's a very used phrase, but it is not the correct one. If somebody engages in this act, we say died by suicide.
Thank you for that. I'm still welcoming. We still have some more time. Welcoming more members of this who have logged in to just ask questions, share opinions, because this is a very important topic in the medical profession. We've noted we've lost quite a number of colleagues in recent past, so we really need to be able to at least help members of our society, our colleagues, and this can only happen if we have the right information.
Hi, if I can make a comment here. Is that okay?
Yes, please. Thank you.
Sure. So the reason that we are highlighting 2 things here, one is the aspects of mental health assessments and the need for increased diagnosis, increased identification by the primary healthcare teams and providers, is because mental health has become very, very big in terms of the presentations that we are getting. The number of cases that we are seeing is exponentially increased. And this relates then and ties in with the suicide risk and our numbers of suicide. We in Kenya have not got very accurate data in terms of the numbers of suicide, but we do know it is high. And post-COVID, this has increased tremendously. And this trend at the moment is not expected to actually go down or even level out. It's actually expected to increase. We are almost on a boom of mental health issues, disorders, presentations within primary care. And we are hoping that at some point, with the tools that Marine has highlighted, using the WHO framework, the recommended tool more or less is the PHQ. What we want to do is try to capture this component of this cohort of patients very, very early so that they can get help early so that we don't reach that point of no return, which is now suicide. That's the whole idea. Because what we realize is that a lot of mental health issues and patients presenting with mental health are slipping through the cracks or slipping through the fingers within the primary care healthcare systems. So we are hoping that we can capture this early, because early intervention, early diagnosis eventually leads to early management of healthcare. So that's the point I wanted to make. Thank you.
Thank you very much for that insightful comment. There's a question in the inbox. Do you think that we will need to change how we give the help? Because many healthcare workers are not seeking the help. So Evelyn is asking, how comes our colleagues are not seeking help for mental health, and we are seeing the outcomes? Yes, maybe we could take this.
Sure, thank you. So as a part of the department, maybe I can chip in, and my colleagues will be able to also contribute here. So we brought in another aspect here, which is the healthcare workers. So whilst we were looking more at from a patient perspective and patient diagnostic perspective, yes, the healthcare workers also need to get pulled in to this cohort so that they can take help, because we do know, and we have seen lately, more and more healthcare workers becoming very desperate to the point of reaching a point of no return, point of desperation, point of hopelessness. And so, yes, there is a need. And the idea here would be awareness, awareness, awareness. And the more awareness we create, and the more we destigmatize and normalize mental health care, the more people will come forward. The more healthcare workers will come forward, so that one, like somebody is saying from Kimani is saying, that we can not only be alert to it, but we can feel free to take the help that is available. Help is available. It's not that it's not. It's just that the people reaching out, especially from the healthcare workers' perspective, is relatively few. And of course, this is understandable, because across the globe, stigma is huge and it's still there. Shame is huge and it's still there. And once we normalize mental health care, not to forget that there's also a need, as Professor Lukoya has been advocating for, there is a need to decriminalize suicide. At the moment in Kenya, if you look at anyone committing suicide, the rule of law comes in very quickly, and this restricts or limits or inhibits people from taking help. So yes, there's a lot of work to be done, but perhaps these are the first few steps to getting there eventually. Maybe my colleagues might want to say something. Feel free. Thank you.
Thank you, Mirali. I want to join also to the next question raised by Kimani, and has raised a very important question that even in the helping profession, as we are also assessing maybe mental health, we are also causing more harm than good, because maybe the helping team is also not in a good mental state. Probably they have not done self-care. And that's why we listed some of the self-care things that we need to check, so that as we are helping, we are also not projecting our pains, our issues to the patient, so that you can be good listener, as I get it from what he said, and it's quite accurate, that you can be good listener, empathetic, and listen to understand, not listen to reply. Thank you. And the other question of Christine, she's asking, at what time do you start medication? I remember when you said the person is being assessed at question 5, they are referred to psychologists and psychiatrists. And from psychiatrist level, the psychiatrist will evaluate on when to start the antidepressant, because they also have to assess, are we dealing with the depression or which other condition are we dealing with? So it's not only depression that can be assessed, there could be other mental health that can be assessed by the psychiatrist.
Thank you. The floor is still open for comments from the panelists and also the members to ask questions. This is a very important and timely topic. Please feel free, let's use this platform. As we wait, I could maybe want to listen to some more comments from Dixit, Kirti. Anything else you'd want to add on this topic as we wait for questions?
I think another thing we can highlight is maybe I can share my screen again and, just tell people how they can get in touch with us. The contact is there. They are able to book appointments with us through that phone number, and they can see our scope of service. It's on the screen. I hope everyone can see the screen.
Well, on that, can you also clarify on maybe when you run some outreach clinics within our network of clinics? Hello, I was asking, do you offer the services mostly at main, or do you also go to outreaches? And when, which clinic?
Yeah, so if I can just chip in here. So we have quite a few avenues here. So within the main hospital, yes, we have 3 psychologists, and Tuesday is our staff day, in which we see staff for free on pro bono basis. But if it's an emergency, then we are able to see anytime when there's a slot or working as an emergency case. In terms of outreach, we have 2 opportunities that have come up. One is that we recently, with Marine Farouk and Shahila Sheikh, we have 2 clinics at, one is at Peponi and one is at the Karen Clinic. But having said that, we also have counseling services available within other outreach centers. There are almost 8 to 10 of them. And that is on a rotation basis, on a booking basis. So counseling has become very widely available within the AKU network, both within the AKUH and within the outreach clinics. And this has expanded now to the outside towns. Mombasa and Kisumu also offer the same. So it is available all along. And Marine is add how she would prefer people to make bookings, things like that.
Thank you for that feedback.
Yes, thank you so much With regards to so I'm currently based at the Peponi Outreach Clinic, and from December, I have my clinic from Monday to Thursday, 9 to 4, and then I have Saturday also, but Saturday the clinic closes at 1. But of course, the last appointment is at 1, so it does push forward to about 2. And of course, we have we can use the Aga Khan call center line. We have the Peponi Outreach Clinic, and the bookings are basically mainly done through the reception, but I'm also accessible. I'm also slotted in with the main hospital, and I think I think the referral system is simple. All the psychologists show there. I think my name should appear there as well. So this is something new. Of course, I thank Mr. Mahmood Mirali to allow the opportunity to explain how the bookings are done. So from December onwards, it's Monday to Thursday and then Saturday.
Thank you very much. I think now we know where to get the team. So I believe it will be of great help to the people we serve. So thank you for that. You are being notified that the CPD link has been prepared. I'll still open the floor to other colleagues, other specialists in the mental health department to please give us some more wisdom, because this is something that is quite of interest to members of the public. And if we can save a life through this, being empowered with knowledge, we'll have achieved our goal. So I'd welcome other members to please ask a question, make a comment, give us some more knowledge and wisdom.
Sure. What I can add is that within the scope of mental health, besides what Marine had highlighted, we are also now able to provide assessment for learning disabilities, different ones. Within the youth group, ADHD would be one, for example, and so on. The spectrum is extremely wide. And as we are going along and certifications are coming in, we are expanding this more and more. Our team is also quite adept trained in mental health, besides counseling alone for the other areas that we have explained on the that we have highlighted on the poster that is showing right now. So this is moving forward in terms of, as a department, we are also growing in terms of trying to now reach out and cover more and more areas within the mental health spectrum. It's extremely wide. We work very, very closely with the psychiatrists, and I know that the Brain and Mind and Department of Medicine is now coming up with a manual for suicide, which they will be launching very soon, and there'll be extensive training ongoing in this area. So I just wanted to add that as well. Thank you.
Thank you very much for your good words of wisdom and knowledge. I think, yeah, that we've learned a lot in this session. We still have a few more minutes. The floor is open. Let's use this opportunity. Anyone else with something more to add? Timothy, seen Prof. Atwoli somewhere? Any other mental health specialists and even general members, please feel free. We are ready to learn. So far, no. So I'm not getting any more comments, no more questions from the members. So we've the CME, the CPD link has been shared in the group, so you can be able to access it through the link. I don't know if anyone has any announcements to make before we come to the tail end of this meeting. As we wait for any final comments or announcements, I'd want to really thank the panelists for the insightful presentations. We've noted with concern the incidents, because if we look at medics, they're just a portion of the entire population. So whatever risk factors they undergo, probably the members of the public are also undergoing. It's just that it's not reported. So I'm glad we are empowered with the right tools, and we've gotten at least some insightful knowledge on how to handle these situations. And also now we know that we have counselors, mental health specialists within the main hospital and our outreach. So we can be able to also refer patients so that they get to benefit and we prevent so many adverse outcomes. I'm really grateful for the good turnout. And I'm grateful to the presenters and everybody who turned out. Yes, as I get to the close of the meeting, anyone with anything else to add on? We're almost getting to 1:30.
I'd just like to thank you for the opportunity. Thank you everyone for being present.
Thank you. Timothy, Mr. Merali.
From Timothy, I also want to thank you and also remind you that what you have shared is something accessible from our team. So in case of anyone who wants a copy, he can reach through Merali, and then we can get a copy.
Thank you for that.
Good afternoon. Zephania from the CME office. This is Shelmy. Mine is to thank you, the participant, the speaker, and you, the moderator, for the opportunity and also for your kind time to make this presentation a success. And also to wish the team and everyone a happy festive season. This is our last CME this year. So thank you for the support throughout the year.
Thank you very much, guys. Happy holidays. Wish you well. There's one last question. There's one last question, maybe as we leave, from Kimani, about any relation with cat consumption in mental health. Don't know who will want to take this as we prepare to exit the stage.
I'd like to have maybe an observation that first of all, cat probably to most people they call it mera. It could be first of all cultural or an area that some community use it as a form of enjoyment, and it's also popular in the young people also. And what you could say is that it's also a stimulant, so that sometimes people would chew it the whole night. I could associate it with leisure sometimes, but if someone is overdoing it, it can also be on the level of addiction. And sometimes when people are depressed, they have a high likelihood to want to chew. So maybe someone who is regularly using cat may end up over chewing at that time because they could be addicted. They might also be going through some form of depression. So that's what I can say for that.
Thank you for that. Thank you for the feedback. Okay. I think finally, I'm grateful for everybody who attended. Thank you for our panelists and those who contributed. I wish you a happy holidays and wish you everyone the best. Thank you very much.